right. Hello, everyone. Welcome to today's webinar. I'm so glad to see you all joining today. Thank you for those who had registered and got my email and joined now an hour later. Sorry for the tech issues this morning, but I'm really happy to see you guys found your way here to the new time. For those of you who don't know me, my name is Hiva Kolodrubetz. I'm a family nurse practitioner. I am also the director of advanced practice here at Archer. And this is a new style of webinar that I'm testing out. So I really want your feedback today. And basically, there's a lot of talk among nurse educators about gamification. How much is gamification really helping our students and how much is it hurting our students? So I thought I would put it into practice and then get you guys to give me some feedback. Because of a little scheduling snafu this morning, I will be scheduling another one of these webinars, not necessarily respiratory edition. I'll probably mix it up with something else, some other pharmacology topic. But I want to know, I want some meaningful feedback from you guys. What are you looking for when you're studying pharmacology? What helps you really absorb that information? And is this a good way to do it? Awesome. Hi, Punja. Very good to see you and Christine. So those who have attended my webinars before already know that I really like to keep my webinars active and engaging, especially when we're talking about topics like pharmacology, where it can be really dense. And students have a hard time really being lectured at. So this is going to be an engaging webinar. Get that chat box open. As I already see some familiar faces introducing themselves in the chat box, I really want you guys to tell me not just where you're joining from, but where are you in your nurse practitioner education, right? In your NP training. The reason for that is because it really does help me tailor the webinar to you, and I can fill in some knowledge gaps as we're talking about it. So, do we need to really brush up a little bit on that pathophysiology? Do we need to go a little deeper on that pharmacology because you've mastered the basics? So, it's easier for me to really tailor it to the audience. So I see a lot of you introducing yourselves both on our Facebook and YouTube channel. So hi, Lynn. Hi, Anitha. Very great to see you guys. And I also see you guys on our Zoom channel. So Booja saying hello. We're grateful to have you here, Abuja, as part of the Archer family. That's so nice. Christine saying good morning. Test scheduled for 9/17. So we have about a month, a little over a month, and farm is my weakest area. And that's why I picked farm, because I hear that a lot from my students. So you're not alone, Christine. Christina says, can we access the recording graduating next summer FNP? Absolutely. This is why we restream not just on our Zoom channel, but so we have the recording living on our YouTube channel as well. So if you go to Archer YouTube, all of these will be living on our YouTube channel, so you can watch this recording as well as other free webinars in the past. And again, we like to mix it up, really bring out new content. So you can go through and see other pharmacology lectures, cardiac lectures, STI, infectious disease, whatever you need a little bit more help with. So great question. Recordings are on our YouTube channel. Hi, Ruthie. Great to see you studying for your boards. Shannon, great to see you taking ANCC at the end of this month. And then Christine said, just finished my DMP ANCC next month. Okay. I'm also, so we have a lecture talking about the ANCC test plan changes that are taking effect in October. I am going to have to move that webinar to the end of the month, but it looks like most of you are taking it before those test plan changes, so it won't affect you guys. But a lot of good things happening in our profession. And I love that our boards, our certifying bodies, are really trying to make sure that we are safe clinicians and really stand behind that with our board certification. So they're adjusting that now in this world of AI and tech. Steve says, hello, scheduling exam within the next month. Joining from Kenya, says Lynn. Very cool. From Florida, Dania, and a lot of from Florida, New York. Okay, very cool. All right, you guys, let's jump into the game. Here's how we're going to play. Here are the rules. I want you to keep track, keep a little tally on your own sticky notes or paper in front of you. But you're going to put it in the chat as well as soon as you get the answer. First, I'm going to show you the clues. And when we're talking about pharmacology, we really want to be thinking about drug classes first and foremost. does this drug fall? What class does this drug fall into? How does that class work, right? What's the mechanism of action in that class? And then for that specific drug, are there things that we need to know for that specific drug? Because not all of the drugs in the same class are going to have those same indications as well as barriers and the warnings and the things that we should be monitoring for. So we're going to talk about that in today's game. And we'll have a couple of rounds with answer choices, and then we'll also have a couple of case clinical vignettes without answer choices. You guys are going to tally it all up, and then we'll reveal at the end whether your score meets kind of that threshold of, okay, I've mastered respiratory pharmacology, or this is a section I need to go back and review some more. All right. So, round one, we're going to crack the suffix. When I am teaching pharmacology, I always tell my students you can't possibly memorize every medication. You have prefixes and suffixes that do help you put that medication into the class that you want to really be thinking about when you're thinking about how does this work in my patient's body. You have to be a little bit careful with the suffixes because there are some outliers, but in general, it's a good way to really help us with the generic name of the medication, really put it in the appropriate class when we're studying. So we're going to crack those suffixes, start from there. Then we're going to go into our other rounds and end with those case files. All right, you guys ready? So I see a lot of students sitting for the exam coming up. This is our quick little window, meet the contenders. Really trying to gamify this. So here are the different classes of medication that we are going to be looking for. Again, think about it in broad terms. How do short-acting beta-2 agonists work? Long-acting beta-2 agonists. So these are our SABAs and LABAs, inhaled corticosteroids. Short-acting muscarinic antagonists, our SAMAs, our LAMAs, leukotriene receptor antagonists, our systemic corticosteroids, and our biologics. So this is what we're working with. Typically in that family here, we have some examples, and then what do they do on a broader scale, right? I was going to try to ask you guys some questions to keep it engaging. What could I do? So somebody tell me how the beta agonists work when we're talking about respiratory medications. How are those beta agonists working in our body? Go ahead and put it in the chat for me. So thinking about that fight or flight, thinking about those adrenergic receptors, right? What happens in fight or flight? We have our alpha 1 receptors, we have our beta 1 receptors, we have our beta 2 receptors. So we are trying to enhance those beta 2 receptors. So what do those beta 2 receptors do? Always think about the underlying physiology. Relaxes those smooth muscles. Very good, Shannon. Absolutely. So those beta 2 receptors are predominantly in our lungs, right? Those are the ones that are really going to open up our airway so we can run away from the danger. If there's a tiger chasing us, our airway is gonna, the epinephrine and norepinephrine is gonna bind with those beta 2 receptors in our lungs, right? Our heart has mostly those beta 1 receptors, right? So when we're talking about beta blockers, this is not the lecture on beta blockers, but we're really thinking about what these medications mean, right? This is a short-acting agonist for those beta 2 receptors. So it's really opening up our lungs. And then we have those alpha 1 receptors on our arteries and those beta 1 receptors mostly in our heart. So those are going to constrict so that we can get the blood flowing to the lungs and other organs to run away from the danger. So think about what are these receptors? Why are we enhancing some of their activity and why are we blocking other ones and those using those antagonists, right? So really thinking about the underlying pathophysiology, that's the best way to learn pharmacology, not just memorize and go and not understand it and forget it. All right, awesome job, you guys. So let's go into round one. We're looking for those drug classes. Keep points, 100 points each. So first one, I'm gonna toss you guys a nice little softball here. The suffix ends in the terol family. We have some examples. So albuterol, levoalbuterol, salmeterol, formoterol. What is the class of medication here? What class of medication? We just talked about these receptors. What class of medication is this, you guys? 100 points. Put it in the chat for me. Short and long acting beta 2 agonists. Yay! Good job, you guys. That's right. Don't be shy. Maybe there's a little delay on the stream, but absolutely these are beta 2 agonists. So if you got that correct, go ahead and give yourself 100 points for that round. So again, how do those beta 2 agonists work? They relax that smooth muscle, help us with bronchodilation, right? We split them up into that short acting and the long acting. We're going to talk about that in a couple of rounds. What do we need to watch for? Why are we watching for these signs and symptoms? Again, it's that fight or flight, right, you guys? So that tachycardia, tremor, hypokalemia. So that patient, and say an adrenergic is an agonist for those beta 2 receptors. So it could potentially also cause some other adrenergic effects, right? So we want to be able to watch for that, educate our patients on that. They really shouldn't be using it heavily because that tells us what? High heart rate. Very good, Ruthie. What happens if our patients are using these beta 2 agonists regularly? It means poor control, poor asthma control. Awesome job, you guys. Okay, next round, question 2, or next question, round 1. What class am I? The suffix ends in zones or onides. Here are some examples. Maybe this is a little too easy, but again, I want your feedback, you guys, after this. So budesonide, fluticasone. What do we think? Okay, Raneem is locking in an answer. Christine, very good, you guys. These are our inhaled corticosteroids. The abbreviation is ICS. Why are these the controller backbone? So, what is the mechanism of action? In your own words, what's happening with inhaled corticosteroids? Can we use them as monotherapy? Is this ever used as monotherapy for asthma control? What do you guys think? Shannon says no. Do you guys agree? Can we use inhaled corticosteroids for monotherapy? The answer is no, right? So it addresses the underlying inflammation in the airway, but it's not a quick acting medication. In fact, if it's used in monotherapy, it can increase the risk for adverse events in our asthmatics. So we really do need to make sure we're coupling it with those beta 2 agonists, right? To get the airway to open up. And then this is going to help with the underlying inflammation, right? So it does reduce that hypersensitivity, but it's not immediate acting like our beta 2 agonist. So never used in monotherapy for our asthmatics. That's not what the guidelines say. So go back and take a look. But when used in combination with those beta 2 agonists, we can use them for both daily control and symptom relief. So both for maintenance and rescue. That's been an update that the guidelines have really transitioned to, looking at death rates in our patients with chronic respiratory conditions. So we definitely want to make sure we're coupling it with those beta 2 agonists, and we can use it for both maintenance and rescue in that sense. Patient education. Why are we telling them that they need to rinse and spit after each use? What are some of those potential side effects for inhaled corticosteroids? Shannon says avoid yeast. I think you mean prevent a yeast infection, so candidiasis in the mouth. Very good. Yeah. So rinse and spit or use those spacers, right, for our little ones. But we definitely want to make sure we're educating them on thrush and also preventing some of those signs and symptoms. All right, going into the next class. So suffix, tropium, idoninium. Sorry. What class of medication is this? What do we think? We've got some examples in there. Yeah, Shannon says thrush. I couldn't think of the word. That's okay. Yeah, what do you guys think? Prevent thrush. Very good, T. Very good, Lynette. What do you guys think? What class of medication is this? What class am I? 100 points. Okay, we've got a couple of you locking in some answers. Altanique, Shannon, Raneem, Luis. Okay. These are our muscarinic antagonists. Very good, you guys. So how do they work? They really block that acetylcholine, right? Help relax those muscles and reduce that mucus secretion. We've got our short and long acting. Big thing to watch for are those anticholinergic effects. Awesome job, you guys. All right, last question in round one. What class am I? The suffix is Lucast, and we have two examples here. I would say the most popular is Montelukast. What class of medication is this, you guys? What do we think? Very good, Louise. Yes, absolutely. All right, Shannon's locking in her answer. Christine's locking it in. What do we think? What do we think, you guys? And this is our leukotriene receptor antagonist. Very good. This is our oral option. So this could be a good option for a patient who may not be responding well to inhalers. It's no longer our first line. It used to be used a lot as first line, but now there's a black box warning on it for those potential adverse effects. So we use this for additive therapy, right? Not just as monotherapy, which is what we were seeing a lot, especially when I entered clinical practice over a decade ago. And again, how does it work? It blocks those leukotriene activity. So it does help by reducing the overall inflammation. It inhibits that inflammatory cascade. But again, that's what can potentially cause those psychiatric events. So we really want to watch this class of medication and use it as additive, not monotherapy. All right, you guys, how do we do on round one? Was that fun? Yay, nay? All right. Yes, you liked it. Okay. I'm learning gamification. So I'm like, maybe let's try it. Let's see what happens. All right, clue cards, round two. So I'm gonna give you clues. I'm gonna give you one or two clues, and each of them are worth certain points. So if you get all three clues, you can count 300 points. If you get two of the clues, count 200 points. One clue, count 100 points. Okay. That's how the round's going to go. First question in this round, three clues, name that class. So first, I work in minutes. Every asthma action plan has me on it. If you need me more than twice a week, the treatment plan needs to be adjusted. And albuterol is my most famous family member. I was kind of contemplating whether I should put that one on there or not, because I think that's a big giveaway. Okay. What do you guys think? What class of medication? All right. And you guys are right. Very good, Sammy. Very good, Shannon. These are short-acting beta 2 agonists. Remember, with these, we do not want the patient overusing that short-acting beta agonist, right? So we always want to make sure we're adding that inhaled corticosteroid, even for those intermittent, mild intermittent asthmatics. We want to really be following proper evidence showing that monotherapy is no longer the recommendation across the board for all asthmatics, all guidelines, right? Rule of two. So big thing, if they're using it more than 2 times per week, it means it's not well controlled. You guys said it. Very good. So we want to make sure we get those inhaled corticosteroids on board and prevent those severe exacerbations, right? So once we started adding those inhaled corticosteroid, we started seeing in the research that about 65% of patients, we started to see severe exacerbations reduced by 60 to 65% in patients that were only using SABAs alone. So big difference there. All right, question number two. Three clues, name that class. Clue number one, I calm the fire, but I don't open the airway. My side effects are mostly local, right? Hoarse voice, white patches in the mouth. I am the controller backbone at nearly every GINA step. What class am I? You're so welcome, Bintu. So glad you're here today. Okay, very good, you guys. And the answer is inhaled corticosteroids, right? So again, how do inhaled corticosteroids work? They do have an anti-inflammatory effect, but they're not bronchodilators. So we never want to use them as monotherapy, right? We can still use them for acute flares, but only when paired with the SABAs and the LABAs, right? So go back and look at the GINA guidelines and review that and make sure you understand inhaled corticosteroids, never monotherapy. Rinse and spit, we talked about that. Systemic side effects. I have a lot of patients who don't want to put their kiddos on inhaled corticosteroid for their asthma because they're worried about systemic side effects, right? This is a big, big topic we need to really talk about with our patients so that we are treating their asthma and preventing those severe exacerbations, right? Those systemic side effects that we see, the adrenal suppression, bone density loss, that's really when we have higher doses over a longer period of time, right? Not necessarily what we're seeing in those low to moderate doses. So please, 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 breathing, airway, ABCs comes down to we want to make sure our kiddos and our adults, all patients are breathing, right? Not ending up in the hospital. So big, big takeaway on this one. We really do see just more localized side effects. All right, you guys. 3 clues. Name that class. Given alone for asthma increases the risk. So never as monotherapy paired with an inhaled corticosteroid. I'm almost in every maintenance inhaler. One of my members acts fast enough to be both the maintenance and the reliever. What class of medication am I? What do you guys think? I think that last point points you, that last clue points you in the right direction. Okay, Raneem, locking in the answer. Christine, locking in an answer. What do you guys think? What do you think, Luis? What do you think, Lynette? What do you think, Bintu? What do you guys think? Okay. So paired with a corticosteroid, inhaled corticosteroid, never monotherapy, and one of the members can be used for both maintenance and relief. This is long-acting beta-2 agonist. So remember, the guidelines have changed, and our long-acting beta-2 agonists are our first line, even in the mild intermittent asthmatics, right? When we're staging our asthmatics, that's what's going to really direct our pharmacologic therapy. And it's still first line because there's one LABA for formoterol. So it's not all LABAs, but for formoterol paired with an inhaled corticosteroid can be used first line for both maintenance and reliever because for formoterol is a long-acting beta-2 agonist, so it lasts longer, but it also has that rapid onset the way our short-acting beta-2 agonists do. So be really careful with this class. It's not both medications are equal in this class, right? It's not all LABAs with an inhaled corticosteroid can be used for maintenance and rescue. It's just that formoterol that has that short, rapid onset and it lasts longer. So good question, Shannon. So she's saying, so LABA is the first line treatment question mark. So absolutely. So we can look at the GINA guidelines again. I pulled them up here. So when we're looking at these GINA guidelines, again, for intermittent asthma, absolutely not all LABAs. So just for formoterol because of that rapid release, coupled with that inhaled corticosteroid, use PRN. That is in track 1 for even intermittent asthma. That's step 1, right? And these are the GINA guidelines. So absolutely LABA, not all LABAs, but formoterol is first line treatment for both rescue and maintenance. Absolutely. Yeah, I know. I think it's a little, you're welcome. Yeah. I think people get a little thrown by that. But again, think about why it does have that rapid onset, and that's why. And again, we do not want to use LABAs as monotherapy. Why? Who knows why? We're not going to be using LABAs as monotherapy. Why? Yeah, absolutely. So the research shows there's a big black box warning on it, right? Research shows in large clinical trials, when it was used, LABAs were used as monotherapy, it was associated with increased risk of asthma-related death and serious exacerbations. So the FDA and GINA both mandate that the LABA must be co-prescribed with the inhaled corticosteroid in asthma. So never as a standalone reliever or controller. Absolutely. And then once it's combined, we actually see that risk flip. So once we have that formoterol with the inhaled corticosteroid, we really see a reduction in asthma-related deaths and serious exacerbations. So it's very interesting. Raneem says not fast enough as reliever and not good enough for anti-inflammatory. Yeah, so again, it depends, right? Formoterol, yes, fast enough as a reliever, definitely. All right, you guys, round 3, rescue or controller, 8 medications on the board, 50 points for each one you get right. You can put it in the chat for me, list out R for reliever, C for controller, and then just list out the numbers. But we've got 8 medications here. I'm going to put a little timer, give you guys about, let's do a minute. Here we go. Oop, instead, we don't want 15 minutes. Okay. There we go. All right, what do you guys think? 8 medications. Shannon, what do you think that one is? So put a C or an R next to it. Is it a reliever? Is it a rescue? Or is it a controller, maintenance? So 1, what do we think? R or C? 2, R or C? 3, R or C? What do you guys think? All right. Keep going, Shannon. Very good. Awesome, Amy. Woo, look at Raneem putting it all in a row, following directions, all in one string. Love it. Christine, awesome job. All right, time is up. Great work, you guys. So for each one you get right, 50 points. Maybe I should have given more than a minute, but if you wrote it down on your own piece of paper, you can count it, right? So quick relievers, albuterol. We have our ipratropium and prednisone. Remember, oral prednisone are going to use for those exacerbations. So those relievers were 1, 3, and 7. Controllers, maintenance therapy, 2, 4, 5, and 6. So budesonide, salmeterol, montelukast, and the tiotropium. So bonus points, again, coming down to that inhaled corticosteroid with formoterol, which is a LABA. This is used in SMART therapy for both rescue and maintenance. Awesome job. How many of you got all 8 right? Raise your hand. How many of you got at least 6 right? 6 or more. That's okay. How many of you got 4 or more right? All right. So this is a nice way to really take a look at the overall picture, take a step back and be like, do I know the underlying pathophysiology of these medications? All right. Last round, we're going to end with some case files, clinical vignettes. Which class comes next? Here, you're not given an answer choice, so you're just going to have to type it in. We're escalating it worth 200 points here. So 45-year-old patient with asthma reports using albuterol rescue inhaler about 4 times daily. What do you guys think? Should that be a red flag? Yes, absolutely. Yes. Shannon says yes, absolutely. Yeah. Wheezing that occurs nightly, right? So remember, we're assessing our patients based on daytime and nighttime symptoms. Do not forget those nighttime symptoms, right? Patient is not taking any daily controller medication and denies fever, chest pain, or difficulty speaking in full sentences. You can also note when you're doing your physical exam that they're speaking to you in full sentences. You hear the wheezing, where you hear the wheezing. That also helps with your documentation. All right, which medication class should be added? Worth 200 points. What do you guys think? Yeah, Shannon's worried about this patient. Very good. Anybody else worried about this patient? All right, Lynette's locking in her answer. What do you guys think? Albuterol. What class of medication is that? So she's on a what? Short-acting beta-2 agonist. What do we need to add? 4 daytime symptoms and nightly symptoms, right? Let's go here and take a look at our scale. Okay, when we're looking at the asthma severity classification steps, she's using SAVA daily, right? Multiple times a day. Absolutely. Somebody said it, severe, right? We're classifying her in that severe category, right? Nighttime, nightly, she's waking up. She has symptoms constantly, right? If she's using it multiple times a day, right? So she is in that severe category. Very good, you guys. All right. So what are we going to add for her? Definitely an inhaled corticosteroid. I would also add a oral steroid here, right? Because she is clearly having an exacerbation that we need to really calm down that inflammation fast, right? So absolutely for maintenance therapy, we should get her on an inhaled corticosteroid. But now for rescue, I would definitely get her on a oral corticosteroid, right? So she's having daily, nightly symptoms, persistent, she's not well controlled. And again, that SABA, we're really moving away from having patients be on SABAs for monotherapy. So she needs to absolutely, going back to these guidelines, absolutely, she's in that severe category, symptoms most days, waking at least once a week. We really want to make sure that we're at least getting her on that inhaled corticosteroid, adding on that oral corticosteroid, and seeing how she does, have her come back in. And then we might need to add some other things on as well. Very good, you guys. Awesome. Okay, going into the next case. So give yourself 200 points or give yourself partial points, even if you knew that it had to be some sort of steroid, anti-inflammatory, right? Case two, 72-year-old patient with COPD. Gold 3 uses LAMA, LABA daily with albuterol as needed. Over 12 months, the patient has had 2 outpatient exacerbations requiring oral corticosteroids with persistent dyspnea on minimal exertion. Which class of medication should be added? 200 points. What do you guys think? Again, pull out those keywords, 72-year-olds. They're telling us the diagnosis. They're telling us what they're on. What do we know about COPD and with this patient having 2 outpatient exacerbations that require that oral corticosteroid and they're having persistent dyspnea, right, with on minimal exertion? What do we think, you guys? What do we think? What do we think? I know this one's a little more challenging. Okay, Christine, she's already on a LAMA, right? She's already on a LAMA and a LABA. Uses a SABA as well as needed. Good guess, though. I love it. Keep guessing. What else? According to the guidelines, what else does this patient need? All right, Raneem, I like that answer. What do you guys think? Amy's locking it in. Shannon's locking it in. Absolutely, we're going to get this patient on inhaled corticosteroid. We're going to do triple therapy, right? So 2 or more exacerbations. She's in group E according to the GOLD guidelines. So we need to have her not only on the LAMA and the LABA, but also inhaled corticosteroid for maintenance, right? So she's having chronic, she's having how many exacerbations? 2, and then yeah, chronically persistent dyspnea. She's not well controlled. We need to have her on that inhaled corticosteroid. Now, why would we not have her on oral steroids? We can't have her on oral steroids every day, right? Already 2 a year puts this patient at risk, low bone density, right? So we definitely want to make sure that we're getting her on that inhaled corticosteroid for maintenance therapy. So going, I know we're over time, but I want to pull some slides for you guys from our 1-day live review, going over those guidelines, really knowing the ABE grouping treatment. So exacerbations, 2 or more, already going into that E category, right? At least 1 hospitalization also puts us into that category. We definitely want to make sure we have that patient not only on our LAMA, LABA, and SABA as needed, but now we're going to add on that inhaled corticosteroid for this patient. Very good, you guys. Okay, so how did you do? Tally up those scores. Let me know how you did. Do you have a pretty solid foundation? You're somewhere in the middle range. Some things you need to go back and review again, but you've got a good foundation to start off. Are you knocking it out of the park? You know your stuff, you got it all right, or for the most part? Or do we really need to go back and buckle down on some respiratory pharmacology? What do you guys think you did? Shannon says she thinks you did okay. Shannon, I bet you did better than you thought. What about you guys? All right. Did we like this? Was this fun? Ruthie says I need to go back. Better than I thought. Christine, okay, cool. So maybe this is a little fun to see, do I know my stuff or do I need to go back and review? And what do I need to focus on, right? So when we're studying pharmacology, again, focus on that class. Those prefixes, suffixes can really help you narrow down what class of medication does this fall into? How does that class of medication work? What are those outliers for those specific medications in that class that I need to be thinking about? And that really helps guide us towards those side effects we need to be monitoring for, what we need to monitor for to avoid those adverse effects, and then those teaching points for our patients as well. So three things, big takeaways. If you don't take anything else away from today's lecture, I want you to take these three things away. Remember, LABA, never monotherapy, right? Significantly increases those asthma-related deaths. Formoterol is the only LABA that we can use for both rescue and maintenance, right? It's a long acting, but it has a rapid onset. And then in asthma, we really want to make sure all the guidelines have moved towards this, but we really want to make sure all of our patients are really getting on those inhaled corticosteroids to help with that underlying inflammation, right? So in asthma, inhaled corticosteroids are the foundation. In COPD, it is an add-on, right? Like we did in our last case. All right, you guys, got to keep reviewing. I hear you, Steve. It's hard, but this is how we learn. We get questions wrong, and it helps us identify the areas that we really need to go back and dig deeper into. So that's really important. Let me know how you like today's webinar. Leave a review. If you have some dense feedback, you can always email me directly. I'll give you guys my email number on the last slide. We do have a live review coming up. So a lot of these beautiful slides that I'm showing you today come directly from our live review. It's a full day review where myself and Dr. Boosie teach from all the way from test taking strategy through all the different body systems, what you need to know, pulling in those guidelines. And we have one coming up at the end of the month. So for those of you testing soon, there is an August webinar, and we're trying to do them monthly. So we have August, September, and October currently on the schedule. And I see a lot of you are saying you'll be at the review, which is great. One thing I will caveat, if you guys have our Sure Pass, make sure you're getting the Sure Pass that's at least for 60 days. Our 30-day Sure Pass does not include the live review, but our 60-day access Sure Pass does include the live review. So it's a really great deal in my opinion. I don't get to set those, but I think looking at what's out there, I think it's a great bang for your buck because I put the content together and I have fun teaching it. So come join me. But yeah, if you are not looking for a board prep, a one-day review, you can also just play around with our Q bank. We have a demo you can play around with. We have over 1,600 questions. We're putting together some new questions for the new ANCC test plan that includes AI and guidelines and ethics around how to use AI in clinic, which is very much part of our reality now. Also, it is emphasizing more on how to interpret diagnostics and not just be able to identify which diagnostic tool would help you make and confirm a diagnosis. So it is shifting because our scope of practice in the real world is shifting. So a lot of good things to come. Definitely feel free to send me an email directly if you have a question on anything. I also work with students one-on-one if you feel like that's something you need. But overall, I am happy you guys joined me today. Despite all the tech snafus, we made it, and I really appreciate your engagement. And I look forward to hearing your feedback on how you like gamification. It was a little challenging for me because I'm always really used to going into the physiology and lecturing, but I'm trying to do more of this gamification that our audience seems to want. So I appreciate your hanging in there with me and testing this out. And more to come. All right. Thank you guys. Enjoy the rest of your day. Bye.